So, welcome back to our live stream, and I have got two fantastic people here with me, the Diet Titans, I call them.
Diet Titans,
I love
we
that
love
name.
that.
So I have got Emma Ridley with me.
Hello.
And I've got Danny, is that right? Yeah.
Danny, yeah. Danny Bear, hi.
I've got Danny Bear. So thank you very much for agreeing to talk to us. We're going to talk about all things nutrition related, especially, nutrition related in the critical illness. So sorry, we're not going to be talking about paleo diets and things like that.
No, thank
today.
you. Yeah,
none of that.
Yeah, definitely.
So, okay, go on then, Emma. Why don't I start with you? Can you tell us what's new in nutrition this year?
Yeah, I think this year's been a pretty big year for nutrition, which has been good. We're having a moment, and I feel it here at the conference. I don't know if you do.
Absolutely,
but yeah,
so good.
It's great. There's a really good vibe, and I think from the research, I think we're starting to look at a bit more of an individualised approach, and I think that's really important. And the research is starting to bear that out a little bit. I think we're not quite there yet, but it's certainly moving in that area. And then I think the post ICU period is also having a moment where people are starting to realise that it's not just what we do in ICU. And for nutrition, we've done very short interventions early in the ICU, and we have some answers around that. But that's only one part of the story, and the patient obviously continues on through their journey, and we need to maybe think about that. So that's what I think. What do you think?
Yeah, I absolutely agree. I think certainly a more individualized approach is what I'm feeling is coming out from not just the studies, but also just more and more about what we see at the bedside with the patients, I think. And also definitely the post-ICU stuff. And that's what really most people ask questions about that. What do I do actually when my patient starts eating and drinking, and then what happens to them when they go to the ward? So yeah, I agree 100%.
I think it fits as well with the whole intensive care movement as well, where in every aspect people are starting to think about what happens to the patient after.
Yeah.
And I think, we used to just focus on what happens in ICU, but everyone's starting to think about, hang on, these patients, they go to the ward, but then they also leave hospital, and how are we leaving them? So I think it just fits with that.
Yeah.
So, okay, let's move on to talking a bit more about the nitty-gritty. So one of the biggest trials that came out last year, which recently was the Target trial, which looked at 1 kilocal per mil feed versus 1.5 kilocal per mil feed.
Yeah.
The results were interesting. What do you guys think? Let's hear your thoughts.
Well, Emma was one of the Target trial investigators, so
I'll tell you what I think.
Congratulations on the trial then. Amazing achievement.
I want to hear what
Great to have
Danny
you
thinks
here.
too. Look, it's been a bit controversial, and that's okay. I think it's a really important trial in my view. I'm completely biased, but it's a really important trial. And I think these sorts of big trials answer big questions for big populations. And I think that's what we need to remember. It doesn't answer questions about individual patients. It's about a big question and something about practice. And so it showed us that early on we feeding is standard care was equivalent to a higher calorie feed, and I think we have to remember it's a 6-day feeding period, so it's very short, and that was the answer that we have. It doesn't really tell us anything about patients who stay longer than that. It doesn't tell us anything about what happens after, but it's certainly very high quality evidence and robust evidence that we have about that early period. So that's what I think.
Yeah, I agree with all of that, absolutely. I think that I don't want to call it an issue because it's not really an issue.
You can have an issue, that's fine. Have an issue.
I mean, it's not an issue. We have some really, really great, very big randomized controlled trials in nutrition. As Emma's already said, it's always a very short intervention, and we always choose an outcome that is probably not going to be influenced by that particular intervention. And the trial is the trial, and the data are the data, and the results are the results. But what I worry about with trials like this, if we keep doing them the way we're doing them for nutrition, is that people always think that means nutrition makes no difference.
Yeah.
And that is always the feedback that I get, certainly from some of the medics that I work with. Well, it's like, Target showed no difference, calories showed no difference, permit showed no difference, so therefore nutrition makes no difference. But of course it made no difference because we chose an outcome that maybe wasn't reflective of the intervention. So, and this is where Emma and myself and a group of us are really trying to change the way we're investigating nutrition trials and choosing outcomes that are maybe going to be more reflective of the intervention and trying to have a longer intervention period. So,
can I follow up to that?
Please.
I think you're exactly right to have that comment, and lots of people have said that to us about the mortality outcome, and I agree with you in many respects.
And just saying we did that same with calories, so it's not,
and so
it is what people do.
The follow-up point for these big trials is that it's really hard to choose an outcome that's objective and that's important to patients and to clinicians, and mortality is that. But absolutely, will a 6-day intervention alter a 90-day mortality? Probably not, and so we do have to think differently about it. I agree.
And also, if you're doing a 4,000 patient trial, you can't do ultrasound in 4,000 patients, or you can't do protein turnover in 4,000 patients, so you have to do something. We just have to be mindful that that doesn't mean nutrition makes no difference to our patients, and I think that's the key.
I think that's the message that we have to get out there, though.
Absolutely.
I mean, when people are saying that, we have to come back with, well, no, that's not right. This is how you interpret it, and I think that's up to us.
Absolutely. Yeah.
I think it's very interesting because the people who are saying nutrition makes no difference clearly haven't gone back into the history of ICU nutrition.
Yeah.
But if you look at the trial from the 70s, it's very clear that not feeding people kills them. But it's also very clear that overfeeding people, which is what we did for a while, where we hyper-supplemented NG and
also
TPA,
kills them.
to get people silly amounts of calories,
Absolutely.
also kills them. So nutrition is a drug, just like fluids are. And so what we're doing now is we're trying to redefine our dosing regime, which is why these trials, in my mind, are so important. So the big questions are. Basically the big question we're trying to ask is, how do we dose our nutrition? And so how are you guys doing that at the moment in your units?
Yeah, so we actually are a big user of indirect telemetry, so we measure energy requirements.
Wow.
So
you've got little box and everything?
Yeah, we've got the little box, and look, there's no definitive evidence whether that's the right way to go, but in our mind, we feel that measuring and using a physiological target is better than an estimate, which is what a predictive equation is.
Well, we measure cardiac output, so why
Exactly.
not measure
Exactly. So what we do is we try and measure. If we can't measure, we will use a predictive equation, and we definitely start slower and lower in the first sort of 3 days of critical illness, and then we'll reevaluate that target and slowly increase our energy and protein provision. So we try and be a bit mindful of the metabolic response to injury, think a little bit more scientifically about it rather than just setting a calorie target and walking away, basically.
Yeah, I think that's your point about don't just set a calorie target, walk away is key. So I also have an indirect calorimeter, but I have the very, very old Delta Track 2 that is no longer serviceable. I used to calibrate it myself, but now they don't even make gas, so I can't use it.
Dedication, right?
Dedication. Oh yeah.
Respect.
Yeah. Thanks. But in our particular case mix of patients, very, very few patients are eligible for an indirect calorimetry measurement, and that is one of the limitations of it. So I don't know that it will be useful for us. We may buy the new one and try it out. We'll see how we go. So I do use a predictive equation. I don't use 25 calories per kilo unless I can't use one of the other equations. So I use one called the Penn State equation, which includes clinical variables like the maximum temperature in the last 24 hours and minute ventilation. So it comes out to be the most accurate compared to indirect calorimetry, but you still have a chance of significantly overfeeding or underfeeding around 15% of your patients, which is a lot. But I don't use it for that reason. I use it because it really makes you think about factors that influence energy expenditure. And my worry with using something like 25 calories per kilo is that we don't often weigh our patients. And if you're not thinking about clinical factors that influence energy expenditure, that patient can stay on that same feeding rate and that 25 calories per kilo for the whole of their ICU admission, and that isn't right, in my opinion. So I think an equation that at least makes you, if you have to use an equation, one that makes you think about the clinical situations that influence energy expenditure, in my opinion, is the way to go.
So let's move on talking a little bit about outcomes, because we already mentioned that. One of the outcomes that seems to be rising in popularity is muscle density and muscle mass as measured by ultrasonography of the rectus femoris. As you guys know, I'm a big lover of critical care ultrasound, so this is right up my street. However, what are the thoughts about that as an endpoint? Because it's a bit of a surrogate endpoint that's potentially, I mean, if you change the angle just a little bit, you could potentially change your cross-sectional diameter by about 5 to 10%. Are we sure that's the right endpoint to be using? What do you guys think?
Danny's probably better place to really answer this because you've done a lot more of it than I have. I don't think it's quite there yet to be using it, in my opinion, but I think it's a step towards actually being a bit more objective. And it might be that we end up with like a surrogate composition of a few different things that we can use, and that's going to be better than just one thing that does not really relate to it.
Yeah, absolutely. And I think ultrasound is 100% absolutely only suitable in a research setting at the moment.
Yeah.
I get contacted by so many dietitians asking how they would use ultrasounds in clinical practice, and it's absolutely not
We're
there
not there
yet.
No.
But I think from a research perspective, it does need quite a lot more work. I think, as you say, you can really change that measurement depending on your technique and depending on where in the thigh you're actually doing your measurement. It can be influenced by fluid. Sometimes in the ICU patients, they are so unwell that you can't even see what you're looking at, and I think that's very hard as well.
And don't really have consistency in terms of landmarking and techniques and stuff.
No, we're all doing something slightly different.
Interestingly enough, there's actually a poster upstairs. Somebody trying to standardise.
Yes, I saw that actually.
Position and thickness. So there's a nice little distance measurement.
Yeah.
It's worth looking at.
Yes.
Please carry on.
Yeah, no, so there are all of the issues that I kind of see with it, but I think it's still worth investigating it to see whether or not it is suitable, and I don't think we can say yay or nay just yet. It's worth having a look at. If we're looking at the effect of an intervention or the trajectory of loss, it's kind of one of our only options at the moment. So, watch this space, I think, with that.
And just randomly, for the physiologically minded out there, why doesn't something as simple as albumin work as an endpoint? Is it just too complicated, too well distributed?
Did you really just ask us that question?
Yes.
That's my favourite question.
People would love to know.
Go for it.
Do it. Albumin is an acute phase reactant, and so with any inflammation or critical illness, it's going to go low, and that is not reflective of a patient's nutritional status or protein stores. The half-life is very short. If I see it again used in an ICU nutrition study, I will be really angry. It is not reflective of nutrition status in ICU. It might be in the normal population, but not in ICU.
That's a nice clap back there. So next time somebody looks at a critically unwell patient and says, "Oh, the albumin is this,"
don't ever refer a patient with that.
And I think that's it. I think that's about all we have time for. And that's a brilliant place to end on. So thanks very much for having us, guys.
Thank you.
It's been great to chat to you and hear things, and look out for more studies from them soon.
Great. Thanks. Bye.